Good evening. I'm Jeff Spence from the Office of Alumni Relations at Thomas Jefferson University, and I'm happy to welcome you to tonight's webinar. Tonight, you will have the opportunity to meet Dr. John Lauriello and hear his vision for the psychiatry program at Jefferson. Dr. Lauriello will share a look at the program while sharing his insights on the future of the field. Throughout tonight's talk, we invite you to share any questions you have by using the Q&A button located at the bottom of your screen or in the Zoom app. We will address questions at the end of the presentation as time allows. If you don't see the button, try moving your cursor and it should appear. And now, it is my pleasure to introduce Dr. Lauriello, the Daniel Lieberman Professor and Chair of the Department of Psychiatry and Human Behavior, and Senior Vice President for Behavioral Health. Dr. Lauriello, the floor is yours.
All right, well, welcome everybody. First of all, I just want to thank you for taking this time out of your day and your evening to be on this Zoom webinar and to hear a little bit about what's going on at Jefferson in psychiatry. Before the pandemic, our plan had been to marry something up with the APA, do a nice reception for friends and family, and you all would have been invited to that, obviously, if you were in Philly or if you were going to the APA. So I'm a little disappointed about that because I would have liked to have met people in person, but I'm glad we have a chance at least to interact this way. Jeff was mentioning what we'll talk about. I don't think I'll spend a lot of time talking about what I think about the future of psychiatry. That's a pretty big ask, but I will talk a lot about who I am, where I came from, and what I see, what I saw as I came into the department and what I'm hoping for the department in the future. And I'm going to say this repeatedly. I'm really interested in your opinions on things, your impressions on things. So I'll start with a short talk. It'll probably take about 20 minutes, maybe a little longer. And hopefully that'll be a springboard to answer some of your existing questions, but to generate some new ones. So let me share the screen here. Okay. All right, so first I'll start basically by telling you that I do have Philadelphia roots. I was born in Brooklyn, New York, and I was raised in Stamford, Connecticut. I went to college at Yale. In those days, people, you didn't have to be incredibly smart to get into Yale the way it is now. And I was able to go there and actually had a very great experience. And then I went to Temple Medical School. And so my Philly roots go back to 1982 when I started medical school. And for those of you who are old enough to know a little bit about what it was like in the 80s, I mean, this is when Cyndi Lauper was a young person just coming out. I saw her in concert years ago. Girls just wanted to have fun. This was in 1983 when the Sixers won the NBA finals. That was pretty exciting. At the time, Temple was doing the sports medicine for the Sixers, so I got to meet Moses Malone and Andrew Toney and Dr. J, and that was a fun experience. It was also an incredibly tumultuous time in Philadelphia. As many of you recall, the MOVE explosion occurred then. My then girlfriend, now wife, was living on Osage, on like 43rd and Osage, and this occurred up in the 60s. So as I said, I went to Temple. This is the old building. It was there when I was a student. It's long gone. I was one of the senior class officers. There's me with the tie, looking pretty darn young. I'm still very close to the president, Kim Strong, who's now Kim Kerr, and she's interestingly a pulmonologist at UCSD and has been dealing a bit with the pandemic. Her son is actually a second year at Temple. I met this gal. This was probably the most important thing I did in those 4 years being in 80s. My wife, Naomi. She became a neonatologist, and she was in private practice in New Mexico for a long time. And then when we went to Missouri, she became an associate professor, and she's now a clinical associate professor at Nemours, but she works at Jeff. We were married in the Adams Mark Hotel. For those of you who are Philadelphia centric folks, that was on City Line Avenue. When I came to visit a few years ago, even before I took the job, I found out that the hotel had been long demolished and a Target had replaced it. So I guess we can say our marriage lasted longer than the hotel we were married in. And here we are I guess I would say the nice old days when you could travel. We went to Iceland last year, and here we are in front of one of the glaciers there in Iceland. So as I said, I went to Yale College and then Temple Med School, and then I went to residency at Payne Whitney Clinic at New York Hospital. That was really a formative experience for me at that time. It still was fairly analytically oriented, but had some really good psychopharmacologists, some good schizophrenia experts who really influenced me. I then did a one-year fellowship at UCSD in basically psychopharm and psychobiology, learned how to do clinical trials, and then an imaging fellowship at Stanford at the VA there. My wife got a job in New Mexico as a neonatologist, so we moved to New Mexico, and we spent 15 years and essentially raised our 3 children there. I ran a very successful schizophrenia research group that was nationally funded, and I was the clinical vice chair and the de facto research vice chair. Then I was recruited to University of Missouri in Columbia, Missouri, and I was there for 10 years. And I'll tell you a little bit about that experience in a minute. And my youngest was a 7th grader at that time, and she ended up moving and really loved Columbia, was actually the salutatorian of the graduation and the president of the class. And so she had a good experience. And then in September of 2019, after what I would call a fairly long recruiting process, I started as chair and senior vice president at Jefferson. So, you might ask, why did I come to Jefferson? I ask myself that sometimes. For me, I thought 10 years being a chair in one place was a perfect length of time. During that time, I had helped build a new hospital, a new psychiatric hospital. There had been an existing state facility connected to the main hospital, and the state essentially gave it to us as part of my recruitment package. And we remodeled it and rebuilt sort of it from the ground up and from the clinical. And it was really, I would call it a beacon in the Midwest, in the middle of Missouri, in terms of psychiatric care. And I built a department we built a department from about 12 people to a faculty in the 30s. We ended up with NIH funding. So I felt, boy, this is probably a good time to go while the going's good and I'm still at a pretty high point. The other thought I had was I wanted to be working for at least another dozen years. And so I thought, well, being a chair for 22 years is a really long time. I will confess, I love Philly, but I miss Missouri sometimes. People ask me, what were you doing in Missouri? But living in a college town, we had good friends. It was really a nice experience. But I'm really excited about being here at Jeff. I mean, I wanted a new challenge. I wanted a more complicated challenge. Little did I know how complicated it would be. And I wanted to develop this role of the senior vice president for the enterprise. Of those of you who have been kind of tracking what's happened to Jefferson over, say, the last 7 years, essentially since Klasko's been president, it's gone from a small couple of hospital enterprise to something like 14 hospitals. And that means that in any kind of delivery of research, academics, clinical care, you have to think about the whole system. So when I think about psychiatry now, I think about what's going on at Abington, what's happening in Jefferson, Jersey, what's happening in the Northeast hospitals. I'm still sort of very busy in the early days with just departmental things down in Center City, but I feel like that'll take a couple of years to kind of get under my belt. And then, simultaneously, the senior vice president thing is really important to me. I had looked at other chairs, and honestly, you have to have the right fit. And I think all the things I had done so far fit very well for what was going on here. And so I feel pretty lucky, in a weird way, lucky I didn't get some of the jobs I really wanted before that I applied for so that I could get this job. I have great memories of Philadelphia. I made good friends here. I met my wife here. It's a really important place. parenthetically, my wife's family is from Philadelphia. Her father went to Central High, her mother went to Olney, and they went to Penn, and so she has always had very strong connections to Philadelphia. Honestly, the kids were out of the house. So after, when in 2018, our youngest was already in college. He's just finished college this year. And my family and then my wife's family actually ended up moving to New York. So we have a lot of family in the New York metropolitan area. My two oldest kids, I have three kids. My two oldest kids have moved to New York City. So for me, it's kind of a no-brainer that I wanted to move back east. And I'm feeling really fortunate that I was able to get this position. So when I got here, and I'll just say that Jefferson's recruitment strategy, I think the dean really wants to keep it at a fairly high level, but I was able to do enough snooping around to see the department and get a sense of it, and even walk in, sort of, sneakily walk through the hospital to kind of find out what was going on before I actually took the job. But we have right now about 31 full-time and 4 part-time faculty. We don't have a lot of part-time faculty compared to, say, what we did in Missouri. We may in the future have more part-time faculty. We'll have to see. We have 18 clinical fellows. We have really robust fellowship in child and adolescent psychiatry, and I can talk a little bit more about that. Psychosomatic medicine and a very good sleep medicine fellowship that Carl DeGramsci runs that is mostly non-psychiatrist, but Carl is a psychiatrist and it's part of the department. And then we have 35 psychiatric residents. My goal is to grow that. We currently have about 10 a year. We'd like to try to keep that as a steady number. And we have a lot of staff now, non-physician staff. I show this list, and I pray I didn't exclude anybody, because whenever you make a list, you miss somebody. But I thought maybe the audience might like to look at it for a minute and see if there are people they know. Of course, Salman Akhtar has been around forever. Ken Serta, Mitch Cohen. These are people that are mainstays of the department. Mike Vergara, who the previous chair, who I think's maybe on the call today, really has done a great job as the chair. Now he's the chair emeritus. And I'll talk a little bit about some of the work Mike's doing down in some future slides. The latest hire is Virginia O'Hare. Some of you who have connections with Drexel will know that she was at Drexel for a while. She's a DBT expert and does a lot of work in medical comorbidities, and she's a real nice addition to the department. What are our current clinical service locations? We have inpatient, both med surg inpatient at Jefferson in terms of and Methodist in terms of CNL. We also have those up at Abington and Jersey and in the Northeast. But just down at Center City, where the department mostly is centered around, we have 2 inpatient services, an ER, fairly busy ER for not being a crisis center, and an ECT service. Outpatient, we're running a lot of different things, mostly based out of 833 Chestnut. We were able to get some new space at the Walnut, at 1100 Walnut for Virginia. Walnut Towers is where sleep medicine is. And so, and we do a lot of work in student health, and we're moving into resident support, which I can talk a little bit about as well. And then many of you may know, is that we have had an extremely long history of working in substance abuse, and NARP, which is on 21st and Walnut, has been around since the 70s, and it runs probably the best methadone program in the city, and an intensive outpatient program. We also support the Family Center, Matir, that does pregnant women, and my sister's place, which also has pregnant women with addictions. One of the things that I'd like to see happen is we'll trying maybe to expand our addictions beyond just a focus on opiates. So we talked a little bit about the faculty number. I would say my assessment, 6 months, 7 months into it, is that we have an extremely strong CL service, CL fellowship. They blow you away, and they make me feel a little dumb, honestly. I thought I was a pretty good psychiatrist, but these folks really know their CL backwards and forwards. We have a very good generalist group, especially on the outpatient side, especially on inpatient. and we have child, as I mentioned, and addictions. But other than the CL, we're not a very deep bench. And this is something that concerned me in Missouri, and it concerns me here. I would like us to get deeper so that we have more people kind of carrying the load, and also more people in case someone would be out sick, for instance, or even leave. We're part of the Farber Institute. And I don't know if that's a new concept to you, but the Farber Institute is really, I'd have to say, is the brainchild and the baby of Robert Rosenwasser, the chair of neurosurgery, who's really nurtured it. And he, with the Farber family, have put together an institute that's really about clinical and research and education. And it includes neurosurgery, neurology, neuroscience, and psychiatry. And I think we, as a psychiatry department, have been the least research intensive of the three. We have other strengths, honestly. I think in some ways we're probably, one of the top education departments. But we do need to build our research profile. The other thing I realized pretty quickly in September was that we had a residency in flux. You all know, probably, even if you live far away, that the closure of Hahnemann created a huge chaos in the city of Philadelphia. Residents were thrown to the wolves to figure out what they can do for themselves. One of the things they had to their advantage is they had their money. So even though the hospital closed, the residency money that went along with each resident stayed with each resident. So in some ways they had something to bring to the table. So what we ended up doing is a lot of them wanted to stay in Philly, and they went all over Philly, but we ended up keeping 5 of the adult residents and all of the child fellows. So that was 8 child fellows. So it was a little bit of growing pains to go from a child fellowship of 3 to a child fellowship of 7 a year. And the other thing that I have noticed, and I've been working very hard on, is there's been some morale issues with the residency. And so we've been working pretty hard on that. And then there's really, surprise to no one, access issues throughout the system, wherever you go. And I've had the experience of living on the West Coast, the Southwest, the Midwest, now back to the East Coast. Access issues are endemic, and access for mental health care is really a problem. I think we had done a really good job of solving a lot of those issues in Missouri, especially training and using PAs and nurse practitioners as part of our compendium of care. And that's something we may end up doing here as well. People ask what your vision of the department is. My vision of anything is really to do the best possible work that I can. I come from a public psychiatry. Even though I trained at Payne Whitney, which is a pretty private organization, the rest of my experiences have been really very much university of state facilities. And I think what I liked about Jefferson is it also, even though it's not a state facility, it has a real commitment to a community and to a region. I think Clasco really believes that. And so for me, it's about training as many providers as I can, not just psychiatrists, providing as much quality care, I would say not Cadillac care, but quality care to the most people possible. Someone tried to recruit me to one of the very high-end psychiatric hospitals, and I went down there, and it was beautiful, and they were really interesting people. But in 5 minutes, I realized that wasn't the place for me. It's not about, I have no problem with people getting Cadillac care, but for me, it's about delivering as much care as possible to as many people. So I want to build the department through this recruitment package that I was able to negotiate. And I want to create this greater depth. In particular, I want to match up with sort of general and child, more strength in the general and CL. I want to marry up more child and addiction strain. So I'd like to hire a couple more child psychiatrists. I'd like to hire a couple more addiction folks. I want to work with the Farber Institute. I have NIH research type hires in my package, although I will say probably those will be delayed because of the financial issues that everybody's having across the country. I didn't mention that we had a space problem in in terms of not having enough space to do all the things we want to do. Actually, we've made incredible headway on this even in 8 months. So we were able to get new space for our psychotherapy clinic, the new psychotherapy clinic. We've negotiated with the dean to use existing space in the College of Medicine to do our didactics, which actually was the dean's idea, and I think is a great idea. I was like, wow, or initially I was thinking, wow, we really want to do that. And I went and looked, and the space was empty, and it's actually phenomenal space. So in the next academic year, we'll be moving to that space just for didactics. And then we've got some funds to do some remodeling of 833 to open up some more space. The Holy Grail, and would have been what I would have said was probable, and now may not be as probable after the pandemic, is that we were going to be moving our small student health to a much larger, slightly off-campus facility that would support residents and medical students. I think that could still be on the table, but everything's up in the air now. I also want to take what I did in Missouri, which was to develop a nationally ranked PA fellowship, and graft that on for nurse practitioners and PAs. We have a lot of access issues. We cannot solve them just with psychiatrists. I still believe very strongly that we should train as many psychiatrists as possible, but even with training double of what we're training now, we still could use more providers. And then one of the big asks of me as part of the SVP is to really think about how do we spread these psychiatric services across Center City, Abington, the Northeast hospitals in New Jersey. There are strengths. We have a great psychiatry departments in Abington and in Jersey. We have really good practitioners in the Northeast, but we really need to figure out how to do some of these things as a group, as an entity, and as a service line. And honestly, I don't know exactly how to do that. I was a chair of a department. I was not a service line chief, and I didn't have multiple hospitals in Missouri. But that's why I came, because I find that will be an exciting and fun thing to do. And the partnership, Diane Custer at Abington and Steve Scheintal in Jersey and Tim Smith in Northeast. These are folks who really want to work with us down in Center City. So I'm pretty excited about that. Well, I can't really give this talk without talking about the pandemic, because it's really affected how we're doing things and how we may end up doing things, and how my vision in September may be different now than it would have been if this hadn't happened. So it's upended things. We still need to hire people, but we're going to be going upstream against priorities not to hire people. But I think we can negotiate that. There are some things that are just kind of basically either replacements or absolutes. I will say there's always silver linings even in the worst things. And one is that it's really brought myself and the folks in the other parts of the enterprise at the psychiatric level much closer. Honestly, it's been a jump into the deep end of the pool with all the other chairs, all the other service line administrators, because we talk every single day now, Monday through Friday, in a way that we never would have done. So I've gotten to know people that I think would have taken me 2 years to get to know just in the span of 3 months. There's just a lot of fear in the system, a lot of fear about about the pandemic, about the virus. I have to remind myself, I just was telling you, my 3 kids are grown, but we have residents with little kids, and we have attendings with little kids, and it's a different experience when you're really worried. What will happen to me? If something happens to me, how will my kids be taken care of, or how would my spouse be supported? For me, it's a different equation now, because my kids can take care. They don't want to hear from me. They want to do their own thing at this point. But there's a lot of fear in the system. There's still fear in the system. There's fear now, what's the financial implications of all of this? I will say, Jefferson is a really well-run organization. And so I think, if anything, will weather it better than a lot of places. But, there will be most likely some belt tightening for psychiatry, for everybody else. But I think it's a recovery that's clearly, it's not it's not quite like the airlines where there may be a question, will people fly again? No, people will see their doctors again. How they will see their doctors could be pretty interesting. And that goes to this point that we ended up dramatically moving all our outpatient care to telepsychiatry. We moved some of our CL services to telepsychiatry, some of our inpatient care, a little bit of it to especially in the beginning when people were really afraid of getting sick. Some of our attendings did their weekend call, for instance, by telepsychiatry. I was on call last weekend and I just went in. Yeah, but it does affect you. You don't want to hang out in the room with the patient for an hour. So it does have its effects. I want to talk a little bit, and I'll show you a slide, a little bit about the department has been really asked in the best possible way, can you as our expert help support the workforce, the providers and the nurses and the techs and the custodians that are on the front lines. And I'll talk a little bit about that in a minute. And as things happen, we've had a lot of interactions with the city. Just turns out that the chief medical officer for the department, the county department, DBHIDS, the disability, I can't remember all the initials off the top of my head, Sosamula Shayinka is one of my old faculty from Mizzou. In fact, I was his reference when he got the job in Philadelphia. So I have to give him a lot of credit. He just keeps saying, well, could Jefferson do something? Could Jefferson do something? And so we have done things. For instance, you may have seen in the Inquirer that we're helping support the quarantine hotel. There's a fair number of people who are going into the quarantine hotel who are on maintenance methadone. And so we have been the folks doing the guest dosing for that group. And then there's been an issue at the airport. So Ken Serta and I went down to the airport. There's been a homeless problem, and we've been talking about how can we help? What could we do? What little things could we do to maybe get people back into shelters and things like that? And I think, if we talk in a year, and I hope we talk in a year, or even 6 months, or if we have another one of these in a year, I think there'll be more things that we will do with the city. My vision of Jeff, and it really harkens back, I will say, to Mike Vergara's vision of, community-based psychiatry, even when he was at Hahnemann and Einstein. I mean, things have a way of coming back full circle, but my vision is to have us get out of our shell and be very much more community-based. And Klasko, I will say to his credit, really feels that Philadelphia and the region is an important, there's service to be done for the people there. I thought this was a slide worth showing to you. So we had kind of gotten our hands slapped that we weren't doing enough telepsych in December. And I was telling folks, we need to think about how we do telepsych. And you see what happened here. We went from, barely 200 to close to 1,400. And that line, this was only data collected in March, that line goes straight. It continues in the 1,500 a month, to the point where, and many of you maybe experienced this yourselves, a lot of folks want to continue this. They want to continue to do telepsych. Our no-show rate has plummeted because we're going to the patients. Surprise, surprise. It is the warmest of handoffs when you turn the TV on and the patient is, warm, snugly in their house and doesn't have to take the train or doesn't have to mess with parking or find babysitting for their kids. Whether providers and whether insurers will support us doing telepsych into the home like they're doing now is an open question. I would like in the future that we continue to do this. I mentioned this idea of the provider support, and here I want to give a real shout out to Mike Vergara. Mike, has been really supportive for me, as the chair emeritus. And when this issue came, how are we going to support people? I asked Mike, I said, Mike, this is right up your alley. This is something you're really, I think you would do a great job. And he's worked with Dina Nubleza, who runs our student health and resident support and a lot of wellness. And we've spent, the last few months, Mike and Dina and Anita Jensen from the enterprise, building a whole structure of supports for people, anywhere from videos that people can watch to going to the departments at the level, warm lines, drop-in video visits, extra visits, EAP, you name it. You can see it through this. And I'm really proud of this. And we've gotten a lot of support on last week. We actually held a interactive webinar. We had made a suicide prevention video. Mike, myself, Virginia O'Hara, and Matt Winterstein did a Zoom video. And then the dean said, can you do a question and answer with the chairs? And Friday, Mike and I and Dina met with the chairs at our regular 8 o'clock meeting on Fridays since the pandemic. We meet every Friday at 8. And they just asked questions, really basic things about how do you interact with folks? How do you approach a person who's depressed? What are the signs of being suicidal? They're worried about their faculty. The dean's worried about his students. So I think we have, stepped up to the task. I was on a call for psychiatric chairs, the Academy of Association of Psychiatric Chairs, maybe 3 or 4 weeks ago, and we were comparing notes, and all of us are building systems like this. I will tell you that we universally have found that people are not accessing this system very well. I'm not sure why that is. It may be that there's so much in the mix of it that they're too tired and too in the moment to let down their guard and ask for help or even feel like they're having a problem yet. But there will probably be a mental health surge, if not in our providers, at least in the people that you all take care of and we take care of, because there's going to be financial hardships, there's going to be illness, repercussions for people who have died. There's just going to be a lot that we need to do. But I'm really proud of what we've been able to accomplish in a short period of time. So I mentioned we're going to have to prepare for this mental health surge. So we're looking to hire more people, and that's going again against the wave of hiring freezes and tightening belts and getting back to some solid footing. I would love to see us do this hybrid of telepsychiatry and in-person care. If we at the end of the day could do 25% of our care by telepsych, I think we would be a better institution, and we would reach out to those 20, and the 25% are those folks that I already told you about, the people that we need to get to because they can't get to us that easily. And of course, restarting the hiring process. I'm already working on that now. We are having serious conversations with other organizations in the region about how we might share services, how we might build things together. I don't think it's time to potentially have to do everything alone. So that's an exciting thing. We're going to, as I said, work closer with the city. In 2 years, I would like to tell you I really understand what the SVP job is, and I'm doing it really well, because it'll probably take me that long to figure all of that out. So we'll have to see how that is. And then we really want to, I have to figure out ways to help support the residents and the fellows more. I think there'll be some changes in the way we run the residency and some of the fellowships. But they're also, they're struggling. They're struggling with the pandemic, struggling about worries about their own health and their family's health. And so, I'm spending a lot of time on that. And I actually love doing that. My favorite thing in the world is to teach and supervise the residents. I don't do enough of that because I'm usually running a department, but that's the thing I love to do. So I'll end with kind of what would I ask from you, and then we can open it up to questions. So I need you all to tell me kind of what's going on out in the community. What are you hearing about Jefferson, good or bad? What worries you? Are there things you think we're falling, down on? And I want that to be an active conversation. So it's easy to reach me. The department website has my email, and you can just contact me. I'm looking for, and this is more local, I'm looking to develop a referral system for not just our patients, because we need that, but specifically a referral system for my residents and fellows. So it's a little bit of a problem when the best residency care delivery system for psychiatry is done by us, and our residents need help as well. So if you're a surgical resident, Dina and Emily Lisco and Sean Blue, we have the people to do it, but our residents and fellows don't want to go see them because they're their friends, they're their colleagues. So I'm trying to figure out what to do about that, because there are been some real barriers. And when I talk about barriers, I would like the residents to be able to go see someone and ideally not have to put anything out of pocket, or if they put something out of pocket, that they can get reimbursed pretty quickly. So I'm not sure how to do that. I'd like to hear if people have ideas about that. I want to thank everybody for past support and financial giving to the department. This is an alumni event, so of course I'm going to put the hat out. Any support we can get from our alumni would be great financially. I'm particularly focusing now on trying to get funds to help support residents and fellows education. I think as the belts tighten, I will have to tighten some of those things in terms of travel. I want to get my residents out there and my fellows out to meetings. Hopefully we'll have meetings, and get them to do the kinds of stuff that sometimes costs a little bit of money, but not a lot of money. So that's pretty much my talk in about 35 minutes, and I'll open it up for questions.
Wonderful. Thank you, Dr. Lauriello. For those of you who are attending, please use the Q&A button at the bottom of your screen and share your questions with our chair. We do have some questions that we have that had come in advance. And one of the questions is, what excites you most about what's to come?
Well,
in a very uncertain time.
Yeah, I mean, I'm extremely excited about what's to come, because, I think, we have I inherited a very good department, but we need to get to be a very good department and enterprise. And so what excites me is that, we've been in our shell a little bit while, say, for instance, neurosurgery, and Robert Rosenwasser is somebody I've just gotten to know over 8 months, but I admire already very much. He has the education, the clinical, and the research mission throughout the enterprise. And we need to be like that. We need to really, what excites me is, how do we take what's good in our department and build on it, especially when it comes to research, because we're a good teaching department, we're a good clinical department, but research, and then, scale that up all the way through all the different components of the enterprise, and an enterprise that's probably going to grow some more. Now, you may have seen in the paper that we've retrenched a little bit. We're not going to do our merger with Einstein, and we're not going to do the Fox Chase. But I think that's a momentary lull, probably. That may be a lull of a couple of years. But I think Jefferson is a far-reaching, ambitious, and smart organization that will want to continue to consolidate and build off the things that they've grown. So what excites me is that's pretty challenging. That's pretty difficult. In Missouri, things are always challenging, but I had kind of done them, and I was sort of getting to the point where I was sort of repeating the things that I had done. Here, everything's brand new. So I think I'll have plenty to do for the next, ideally, dozen years, which I see as my times, my range of time that I'd like to work on this.
Excellent. We have a clarification question that's come in, and if you could maybe clarify for some of our attendees the difference between the enterprise and university.
Yeah, so that's a good question. So the university and the enterprise are in some ways synonyms. The enterprise tends to be seen more as the clinical arm of the university. So that's all the hospital systems. That's the hospital system, the 14 hospitals. But what I like very much about Jefferson is that, Klasko and the dean and Bruce Myers, who's the chief of the clinical arm, pillar, they're all working together under the same envelope. There are institutions in which the university part is so completely separated from the medical part that while it may work nicely for, in their silos, that disconnect really does end up costing in the long run. So yes, everything's under the university, under Jefferson, but the enterprise, when I say enterprise, I'm usually talking about the hospitals.
Another question, what is the relationship with the integrative medicine department at Jefferson and perspective on the mind-body connection, gut-brain axes, et cetera?
Great question. So Dan Monti, I think, is a visionary. And in his vision, I actually think is very subtle, because he said, I don't want to be a center of integrative medicine. I want to be a department. And when I asked them, I don't know why, I don't know if he said it or I asked them when we were talking, he said, I want there to be a department of integrative medicine in every medical school. And so by creating it as a department, I think that's a really critical, subtle but important thing, because centers, they're patchy. But departments, every medical school has an internal medicine department and a psychiatry department and a surgery department. And he wants to have an integrative medicine department. Now, I made the mistake of saying, well, are you talking about alternative medicine? I guess that's not the word to use, because in some ways, integrative medicine can often be confused with integrative medicine with primary care. And that's why I asked for the distinction. But this mind-body, and Madeline Becker, who had been in our department for a long time, is now one of the leading faculty members in that department with Dan, who's a psychiatrist. And she is still part of our department, as Dan is still, she's still got a secondary appointment in our department, as Dan does. So I would like to see us grow our relationship with them. I think the kinds of questions they ask are questions that we as traditional psychiatrists are not asking. So when I got to meet Andy Nurnberg from that department. He is a brilliant guy, and he's working on looking at, imaging and research, looking at alternative types of medicines that we just don't do. Vitamins, amino acids, things like that. I think that's going to be, I think we would hopefully have in the next 5 years an extremely strong relationship with them.
On the partnership front, we have a question wondering if there's any possibility, or if there is an existing relationship with the Lemert Center for Medicinal Cannabis, rather.
I don't know. I know that there had been a connection with cannabis just prior to my coming that kind of got disbanded. So I don't know the answer to that, honestly. That has not come up on the list of people who have approached me. But I do think, I will say that I envision cannabis being legalized across the whole country. And I think that cannabinoids will have to be integrated into our care model, but also integrated into our social model in the way that alcohol is now integrated, for better or for worse. And so I do think that that ship has sailed. Cannabis will be part of our life in the future. And I think we should try to figure out the best ways to use it, and also be aware that there could be some collateral damage. I'm a schizophrenia expert. I have an expertise in first episode psychosis. That's cannabis and first episode psychosis. That's a bad combo. So if someone has the underlying vulnerability psychosis, a lot of cannabis could push them over the edge. And we've seen that. Studies have shown that when liberalization of marijuana occurred in Great Britain, the rate of psychosis went up. So there will be great benefits to it, and there will be some collateral damage as well.
One of our attendees points out that one of the biggest obstacles for residents and fellows having access to their own mental health care is that they cannot come during even extended work hours. And we wonder what kind of support might be existing or developing for Jefferson residents and fellows in that regard.
I think it's a really good point. I think we need to be flexible if possible, especially if providers are going to be flexible. If they're going to be flexible in the way that they allow our residents to come, then we have to figure out ways to allow our residents to come. It's difficult when you're an intern on internal medicine or an intern in the ER rotation to say you're going for your psychotherapy or for your psychiatrist visit. It's just not in their culture. I trained at Payne Whitney, and that was definitely in the culture. And people were routinely going for their therapy during the day, and people accepted that. So I certainly think we can do that in some way or another in the third and fourth years, harder in the first and second years because they have these sort of very embedded clinical. But I will support being flexible if we can do that.
Wonderful. We have a testimonial from one of my attendees who said, a graduate of the residency program, they've had a great career and now a PI in many clinical trials. After a long academic career, they wonder how they can be of help to Jefferson in this area and how they could be of help even as an off-campus resident supervisor?
Just call me. I absolutely need you all, and that kind of person who's done those kind of clinical trials, because we used to do clinical trials. The sleep medicine people still do a lot of clinical trials, but we've kind of not been doing very many. I would love to see if we could revamp that. So please call me at the department, and we'll chat. And we do need supervisors, and so we'll figure out how to get you involved.
Wonderful.
And I'm glad you had a good career. I think that's a real testimony of the training that Jefferson has done. Whether you were a medical student here or a resident here, I think the training is excellent.
You mentioned expanding the department's addiction services. Could you expand on what you are seeing in that, how?
So Steve Weinstein's been around a long time. He's still in our department. And, I asked him a little bit about the history. And, the history years ago of the department was that it was it was more well-rounded when it came to addiction treatment. So alcohol and cocaine and other things like that were treated as much as opiates. As like anything, the money tends to drive where people end up. And the money really has been over the years in supporting opiate treatment, at least here in Philly. I want to blow that up a little bit. I want to keep NARP. I'm so proud of NARP, and I'm so proud of the work we do at Mateer. But even Bob Sterling, who runs NARP with Bill Jangro, they want to have more flexibility than just giving methadone. They want to use Suboxone. They want to do other things with those folks who have opiate addictions. They also are hankering to treat alcoholism. There is still some cocaine, some other drugs. In Missouri, we had a huge problem with amphetamines. Unfortunately, they're not that great treatments for amphetamines. Here, there's some of that as well. So I don't want to throw out what we're doing, but I want to expand. And what I would like to do is to go from right now, we currently have 2 psychiatrists. I'd like to go to 3 or 4 psychiatrists and maybe even a nurse practitioner, just to do more things for more people.
Great. We have some more questions coming in.
Good.
One is, how do you see the future of having mental health services in primary care offices and the potential for joint residencies?
Yeah, this is really happening as we speak. So we have in our department Rochelle Renee, who's running these behavioral consultants in our primary care clinics. Mike Vergara has been very involved in this as well. This was one of his babies in the last years of him being chair. And so we're embedding these behavioral consultants in the primary care clinic. And I think in the ideal world, we'd have, and I would say I would do this by telepsych. What I'd love to have happen is that we can just Zoom a person in quickly to see a psychiatrist while they're still in their primary care clinic, or vice versa. So I think the wave of the future is to do more integrative medicine. That's what's confusing about integrative medicine, because integrative medicine also includes integration between primary care or medicine care and psychiatry. Jürgen Unzler is the chair at University of Washington. His group are the fathers and grandfathers of this integrative care. And I wrote Jürgen because he had written me about how to start a psych hospital, because I had done one, because he had to start one in Seattle when I was in Missouri, last year. And I wrote him this year saying, hey, what do you guys do in terms of standardizing integrative, psychiatric care in primary care? And he says, I don't have anything. And I was shocked. So one of the interesting things is they're not even sort of best practices that we could disseminate. So we're working on, before the pandemic, that was pretty high on my ask list from the enterprise, which was, how do we standardize how we might approach a depressed person in all these clinics? And it turns out that there are some very good standardized protocols that have already been built that are free to use. And we were in the midst of kind of working on that. So, and then the last thing about the combined residencies, there's about 6 combined family medicine psychiatry residencies in the country. They're incredibly competitive. There are a lot of students who want to do this. I don't know. I don't know if we could do it or not. I think we could. I mean, the problem is the funding. We have a great primary care department, and we family medicine department, and we have a great psychiatry department. So there's no reason we couldn't do it, and we could easily fill it if we had the money to support the lines.
Excellent. Lastly, on that note and ending on a good note, an alumnus has written in to let us know that he would like to spend money to support the residency program and asking how to do that. So we'll be sure that he gets that information as well as our other attendees.
Jeff, could you send them my contact information as well?
Absolutely. All of our attendees will receive an email tomorrow thanking them, providing additional information, a link to support the program, and how to get in touch with you.
Yeah, and I would just say, listen, the chair, here's the best secret or the worst secret in the world. The chair has the easiest schedule of all. They have the most openings. Now, they do the most worrying, so they get the most gray hairs, but they do have the most flexible schedule. And so if you wanted to come visit, please contact me and come visit and come see the department. Come talk to me for an hour. I'd be happy to do that. Now, we have to do that by Zoom now, but in the future, we'll do it in person.
Yes, and we all look forward to that. Thank you again to everyone who has joined us. I hope that you have enjoyed reconnecting with the program and learning more about where we're going. We hope that you'll also join us for some of our other upcoming alumni webinars and talks. Later this month, we will have Jade Papa, curator for Jefferson's Costumes and Textiles collection, who will share pieces from the university's collection while sharing tips you can use to preserve the important textiles in your life. That could be anything from wedding gowns to sports jerseys.
Jeff, someone sent me a little birdie sent me a reminder to tell people that I forgot something very important, that we did get approval for an addictions fellowship that we will start. We're going to start this coming next July. So if you know residents who want to do addictions, there's only 2 addiction fellowship slots in the city. They're both at Penn. They're both VA oriented. We will do I'm going to tell you, a better one that's going to be city oriented, community based, have all these amazing things. So that's a highlight. I forgot something. Somebody told me, hey, you forgot that. So I'm telling you about
It's good to have friends.
So, and the other thing, because I know this was a pre-question, we're also moving towards, if we can get this psychiatric addiction fellowship running smoothly, we're looking at about even expanding it to the addiction medicine fellowship, which would allow family practitioners, internal medicine, other folks to become addiction specialists. Okay, sorry, I had to add that in.
No, that's wonderful news.
Time was up.
That's great news. And thank you all again for joining us. We have some great programs coming up. And as I mentioned, in your inboxes tomorrow will be more information and a link to support the residents and fellows at Jefferson. Please have a great night. Be safe and stay well.
Thanks, Jeff. Thank you a lot. Thanks, everybody.